We're so excited to get this conference started with a topic near and dear to our hearts. So I'd like to introduce also Dr. Seth Lerner and Dr. Guy Godoy, who are my partners at Baylor. Dr. Lerner is our Chief of Urologic Oncology, and the three of us will be going through some cases in non-muscle invasive bladder cancer here. So just a quick disclosures for all three of us, lots of clinical trials and advisory boards. All right, so case one is a 73-year-old man with gross hematuria. Certainly we can see endoscopically how this tumor looks when he comes in for a clinic cysto, and likewise on his imaging, a filling defect on the floor of the bladder. He has been a former smoker but quit quite a long time ago and does have kind of typical past medical history. He undergoes TURBT, and this tumor was approximately 3.5 centimeters, large by endoscopic estimate. Staging studies were all negative for any nodes or distant metastasis, and the path returned high-grade T1 with negative muscularis propria. Of course, always critical to know the status of the muscle with the staging, and there was carcinoma in situ present as well. He undergoes next a restaging TURBT, and the path is no residual malignancy. So in this grouping, these are the AUA non-muscle invasive risk groups that came out in 2016, and these guidelines went away from the former guidelines, had all index cases, and that became very confusing. As you know, in non-muscle invasive bladder cancer, there are so many time points and so many recurrences. The case index case became a little cumbersome to follow the guidelines. So in 2016, they went to more of a format that was based on evidence, but grouped occurrences into the three risk groups here. And for our patient, having high-grade T1 with any carcinoma in situ, either or, puts him in a high-risk category. So these guidelines state, they have a lot of caveats in the guidelines that you can read about which treatments are necessary for which risk group, but in these guidelines they write that for a high-risk non-muscle invasive bladder cancer patient, we should consider perioperative intravesical chemotherapy, and we should give induction intravesical therapy, and the patient should receive 3 years total of maintenance BCG if there is response seen with induction BCG. For high-risk non-muscle invasive bladder cancer, BCG is first choice as the intravesical agent. And I would just direct you to several guidances that are available now because of the shortage. The AUA does have a bit on their website, and also there's a letter that you can find through Beacon's website and also through the AUA website. This was a joint statement written by the AUA in conjunction with the SUO, the AACU, the LUGPA, and Beacon to come up with some best practices in the circumstance that we're in right now, where BCG is not readily available in the amounts that we would need. So from this joint statement, those patients that have high-risk non-muscle invasive bladder cancer are the ones who should be prioritized for full-strength BCG. If not available, these patients or other high-risk patients should be given reduced half to 1/3 dose. If supply exists for maintenance therapy, every attempt should be made to use 1/3 dose and limit total duration of treatment to 1 year. In the event of BCG supply shortage, maintenance should not be given, and BCG naive patients with high-risk disease should be prioritized for induction BCG. So above all else, induction BCG for high-risk AUA group patients is the highest on the list. Dr. Lerner will give us a little more insight into where some of this guidance came from and what we know from the FDA and from Merck.
Thanks, Jen. So I've been fairly deeply embedded in trying to address this issue from a policy statement and from an advocacy statement. I wear a couple of hats in terms of I've sit on the board of directors of Beacon. That's an unpaid, no financial association, but I'm a huge advocate. And as you'll see, near the end of this talk, we've got a clinical trial that might help solve some of this supply issue. So The background is that, as you know, Sanofi Pasteur, there's a company in Canada that made Connaught strain, which was the other strain that was available to us in North America. They basically went offline in 2012. They had a contamination issue in their plant, and despite a lot of hand-wringing and machinations, basically never came back online. And so that leaves Merck as the sole supplier for Tice. And what you may not be aware of is that they are the sole supplier of BCG in 70 countries. And they have done everything sort of possible to ramp up production, having increased that by about 100% over the last couple of years. And those are the data that they've provided in terms of their production. And you're also probably aware that when this shortage became evident, they've managed that on an allocation strategy by their sort of third-party suppliers that we all interact with in an effort to get BCG. And that allocation was based upon historical utilization, pure and simple. And so there's no preference for academic sites, community sites. There's plenty of academic sites in this country that are having a great deal of difficulty getting BCG. So now this is my opinion, is that it's highly unlikely that Merck will be able to do anything in the short run. Whether they will do anything in the longer run to try to further increase their supply, I predict that won't happen. Not because they don't care. You're probably aware that they don't get paid a whole lot for this, and it's a big company. So Merck, again, my opinion is they shouldn't be thrown under the bus. They're doing everything they can, but obviously this is a huge problem for our patients and for all of us that are trying to take care of our patients in a helpful way. So what are the data around dose reduction? So there's a fair amount of data that you can get an adequate cytokine induction with lower doses of BCG once the patient their immune system has been primed and they recognize BCG. So that's why in the guidance statement we were we focused on the newly diagnosed high-risk patient. I just want to get out there very quickly. Please do not use this for intermediate-risk patients. Please don't ever use BCG for low-risk patients. It's not indicated. But reserve BCG for the high-risk patient. But once past induction and you've got immune memory, the whole idea with 3 weekly instillations is that you reach peak cytokine production by the second or third dose, so you don't need to give any more. As a matter of fact, if you give more, you can actually suppress the immune response. And you can get that immune response with dose reduction. And I'll come back to that in just a second. So this was a trial that's been published and run by the EORTC, which asked a question about full dose, reduced dose, and 3 years of maintenance versus 1 year of maintenance. And the take-home message on the high-risk disease patients was full dose, 3 years of maintenance. So the standard of care hasn't changed. That was established by SWOG 8507, which was a randomization to 3 years of maintenance versus no maintenance. And so at least the data comparing 1 year versus 3 year clearly is in favor of 3 year. Now, does that mean that 18 months isn't good enough or 24 months isn't good enough? And I can tell you what I suspect the three of us are doing is taking some of our patients that have done well, maybe having a little bit of prolonged side effects, and probably stopping maintenance at those longer intervals, probably starting to think seriously about it around 24 months and certainly 30 months. So the AUA has been working on our behalf, and there's a J-code now for reduced dose BCG. The problem is that the payers haven't come on board with giving us a way to submit a claim or payment claim for taking a vial and splitting it between 2 patients or 3 patients. There's a J-code for it, but it doesn't help if the third-party payers haven't given us a way to to use a vial for more than one patient. So you'd be treading on fairly thin water if you do that. Now, I'm not going to tell anybody that you're doing that. I have professional colleagues of mine that are just sort of ignoring that and doing it, but unfortunately right now you can't. So it doesn't make a whole lot of sense to me to take a vial and give half of it to one patient and basically throw the rest of it away. You can't do that. But dose reduction is nevertheless an important way of managing toxicity and side effects. And hopefully Neil Shore and another guy are working very hard with the AUA and the payers to try to solve this problem. Because you can imagine if I could now take a vial and treat 2 patients or 3 patients that are on maintenance, that's going to have a pretty profound impact if we all do that on the supply issue. So a number of us work with the FDA on a number of different issues. The FDA is certainly aware of this, but their position is, come to us with data, come to us with novel trial designs so that we can, in the future, perhaps have an alternative to BCG. Let me go on to a particular issue of strain differences. So on the left is the phylogeny of BCG. You see that it started way back in the very early 1900s at the Pasteur Institute, and as this is a live bacterium grown on potatoes. And so over the years, you've had mutations in the genome of this BCG that potentially have an impact on its immunogenicity. So what you see on the right is a comparison done in Europe in patients who got induction Connaught versus induction Tice, and you see that Connaught was much more effective. The European population, though, is probably an immunized population, right? Because most of them got TB vaccinated. But there was no maintenance in here. So whether or not this translates to a more conventional North American patient population, we don't know. But there's some data to suggest that there are some differences in strains. And then this is the Tokyo strain on the left, which phylogenetically is very similar to the Connaught strain. And you can see this was a comparison of Connaught versus Tokyo, and Tokyo seems to have efficacy a bit more like Connaught. Hold that thought, because I'm going to come back to it in just a second. So there's a company, Verity. Their business model is repurposing old drugs or bringing them sort of out of the dark. I have a consulting relationship with them as they are planning to go to the FDA with the Russian strain, which is produced by the Serum Institute of India. That's their relationship is with the Serum Institute of India. There's lots of data on the Russian strain, and they intend to file. They've actually filed in Canada. And they feel like, and the experts in Canada feel like they're very likely to get approved to be able to distribute this in Canada. If that happens, they'll take that package to the FDA. So that's another way that potentially the supply could be helped, but it's highly likely, and this is my opinion, that they're going to have to do some sort of study here in a U.S. Patient population. So stay tuned on that. So one way, and this is sort of a little bit of shameless promotion, but in one of the hats that I wear is chair of the Bladder Committee in SWOG. So we've got a very innovative clinical trial that's been accruing at like gangbusters, about 40 to 45 a month. The research questions are, is Tokyo strain non-inferior to Tice? Whether or not that's an approvable endpoint, we don't know. And then is an immunization strategy, pre-treatment immunization, just a TB vaccination to prime the immune system, does that lead to improved 12-month recurrence-free survival? So it's a 3-arm study, Tice versus Tokyo plus priming, and everybody gets 3 years of maintenance. So for our patients who are going on this trial, obviously we're cutting our Tice utilization by 2/3. This trial is open all over the country, and I'm sure there's places that have it open near you. And so I would perhaps propose that if you don't have BCG, or you're really sort of commandeering it for a select group of patients, just go on the NCI website, clinicaltrials.gov, and see if there's a site close to you in November. Because right now we had to close the study temporarily because of a contamination problem in the diluent for the vaccine. That's another story. But it'll be up and running back in November. So this has the possibility, if it's a positive trial, of maybe getting the Tokyo strain into the market. And those are big ifs, and lots has to happen for that to occur, but there's an opportunity there.
Thank you so much. So back to our patient. He completed induction BCG, received a total of 6 doses, full-strength BCG, which he tolerated well. His first cystoscopy at 3 months or 6 weeks after completing BCG was without recurrence. The cytology at that time was negative. We were able to use fluorescence cystoscopy with flexible cystoscope, which is now available and has been FDA approved for a year. He then received maintenance BCG, a total of 3 doses, full-strength, given some availability. However, after his maintenance BCG, his second cystoscopy showed a suspicious papillary tumor and other areas of erythema. TURBT was done, which now showed high-grade TA disease, non-muscle invasive, but again, presence of carcinoma in situ. So this is just an example schematic. If a patient starts in the beginning with a high-risk disease, high-grade TA, high-grade T1, TIS, receives induction BCG, hopefully has a negative cystoscopy and negative cytology, maintenance BCG is the right answer. If the patient completes induction BCG but has a positive cystoscopy and or a positive cytology, you need to determine what is the pathology causing that. If it's high-grade TA or carcinoma in situ, you can re-challenge the patient with a second course of induction BCG. However, already, if the patient has a high-grade T1 after completing 1 course of induction, that is BCG unresponsive, and that's what we're going to talk about next. There was a definition created in 2015, which Dr. Lerner can tell us a lot about the origins of that. It had a lot to do with the FDA and clinical trials and trying to harmonize endpoints. But this was recently revised in coordination with the FDA, and this is a summary of the qualifications that make a patient's cancer BCG unresponsive. The patient must receive adequate BCG induction, which is at least 5 of 6 doses. The patient is unresponsive if their cancer is unresponsive if they have high-grade T1 at the first evaluation after adequate induction. The patient could also be classified as BCG unresponsive if they have carcinoma in situ with or without papillary disease, TA or T1, within 12 months of adequate BCG course. And an adequate BCG course is here, at least 5 of 6 doses induction and either repeat induction or at least 1 round of maintenance. This is a lot of qualifiers and definitions, but it became very important to come up with these definitions so that there could be more easy comparison between all of these single-arm clinical trials. The patient can also be classified as unresponsive if they have recurrent or persistent papillary disease within 6 months of completing adequate BCG. And this was the main change from the original set of definitions to 2018, was just there was a little more expansion of the timeline. So our patient is now qualified as BCG unresponsive. What can we do now?
I've learned a lot over the last few years in designing these trials and going through this process of trying to define this patient population. So the FDA basically went to a group of us and said, come up with criteria to describe a group of patients who should no longer receive BCG. It's really very similar to the old BCG refractory, but we coined this term unresponsive, and that's sort of what's in the nomenclature now. But one of the things in designing the trials is that the patient who has evidence of persistent CIS at that first cysto evaluation, which essentially is 3 months after start of induction, 6 weeks after the completion of it, even if they have evidence of CIS, let's say there's a little area of erythema, you have a positive cytology, they can stay on BCG. So they should get another 3 weeks of BCG, and we really wait until that 6-month time point, and we do biopsies at that point to verify the response, because the data from the SWOG maintenance trial showed that without additional BCG, induction only, a percentage of patients will convert to negative without additional therapy, about 12 to 15%. But with 3 weeks of maintenance, that number near doubled, and the CR rate, complete response rate at 6 months, was around 85%. So that's why in the setting of CIS, we don't bail out at that 3-month mark yet. So hence 6 plus 3. the conversation that we all have to have with the patient who's deemed BCG unresponsive is that our guidelines, and I would argue that pretty much all the society guidelines are consistent in recommending radical cystectomy. And the rationale for that is that this patient population is at much higher, presumed higher risk for progression to a muscle-invasive cancer, and that the cure rate with radical cystectomy when the patient has a non-muscle invasive cancer is extremely high. It's 90% plus. And there's no drug on the planet that offers a complete response rate of 90+%. Now, granted, cystectomy is a big operation. It has mortality risk, morbidity risk, so there's a tricky little balance there. But that's the conversation we all have to have with our patients. And this is one of the reasons why. There's no a priori need to prove that the patient has muscle-invasive bladder cancer to justify a cystectomy in this patient population. And that's one of many studies that have shown this dramatic drop-off in survival probability when you do this with a muscle-invasive bladder cancer as opposed to treating prior to that. And that's on us. That's really on us to follow these patients very carefully and not withhold potentially life-saving surgery. But naturally, our patients they're not lining up out the door to have cystectomies. They'd rather save their bladders if it's safe to do. And so these are the current off-trial alternatives. So as you know, Valrubicin is currently the only FDA-approved drug for the language is BCG refractory CIS, and the criteria would be the current criteria. Does anybody use Valrubicin today? Okay. Part of the reason is, I'll show you that you're all aware of the data, it's not a very effective drug. There's some data on gemcitabine. Actually, there's a lot of data on gemcitabine. It's a very effective drug. This is all intravesical. Optimize mitomycin C. You can improve the delivery of mitomycin with heat or microwave. And then combination chemotherapy, which has been pioneered by Mike O'Donnell, is kind of currently what we're using. And then obviously, if you have a clinical trial available, that, in my opinion, would be the best way to go. So this is the data from Valrubicin. This is why it's not used very much. And this was the impetus for the FDA to do the right thing and establish a registration pathway for new drugs to get into the market. Because there was no comparator. No one was willing to do a phase 3 trial and compare it to Valrubicin because we didn't want to give our patients Valrubicin. And I'm not trying to throw the company under the bus. It's just the reality of the data. But that's part of the conversation. You have to tell them that there's an FDA-approved drug for what you have. This is one study amongst many. This was a phase 2 trial we did in SWOG, which shows the efficacy of gemcitabine. You can see that it's an incremental improvement over Valrubicin, but still the majority of patients are recurring certainly after a year and definitely after 2 years. But it might, if you're in that 20%, for you, it's a home run. Docetaxel, the taxanes have been pioneered by Jim McKiernan at Columbia, and this is his data from a recent publication. Actually, now it's 6 years old. But here's the combination, and this is kind of what we're using today, Gem-Doce. There's two really good publications. The first one was from Mike O'Donnell. The second one was from Trinity Bevilacqua at Hopkins. This is an easy regimen to give. We give the Gem first for an hour and a half, then give the Doce for an hour and a half, so it's a little longer time in the clinic. Very well tolerated, and you can see here, if you pay particular attention to the top graph, that there's about a 50% durable CR rate at roughly around, certainly at 12 months, and then it drops off after that. Now, that's better than anything that we've got so far, but this is not a clinical trial. This is a cohort. It's retrospective with all the limitations of that and patient selection. It's a mixed group of patients. But we're using this. We've probably I've treated about 20 patients, and I would say that we're seeing very similar results. So off trial, this is what we're using. Mitomycin is a very effective drug, intravesical, particularly when you can drive uptake into the wall of the bladder with in this case, device-assisted, either microwave or heating the bladder through a variety of different catheters. I have no personal experience in that, so I'm just sharing the data with you. And so the FDA put together, I don't think I'll go into the details of this, but they essentially approved a registration pathway for a single-arm trial design, so no comparator. But what that means is that the target population is patients with CIS because they have biopsy-proven disease at the beginning of treatment. Whatever your intervention is, if that CIS is no longer present, it's because of the drug. On the other hand, if you use it as an adjuvant for papillary disease, resected papillary disease, you have to do randomization so that you can get an accurate readout on the efficacy of your drug compared to no treatment or a placebo. So it's single-arm trial design. The target population is with CIS. I'll just run through some of the trials that are out there. We had funding to do this trial with this antibody-drug conjugate. We put one patient on the trial. I do know that they're preparing their FDA application. I think it's a drug, if you look at the bottom, that's going to have a bit of a difficult time meeting the bar for registration, and I believe that their backup plan is to do combination with immunotherapy. But they've completed their trial. It's a very intense regimen. It's essentially twice a week for 12 weeks, I think. And so I think that also is going to be a challenge in the marketplace. But stay tuned because they could get approved. And then this is a trial that we've been doing that is completed accrual. This is in SWOG. It's atezolizumab. You're familiar with that, one of the IO agents. You'll hear more about that later on in the presentation. That's the study scheme. So they get it on a Q3-week schedule, just like for patients with metastatic disease. The endoscopic evaluation follows along our 3-month routine and a 6-month biopsy-proven endpoint. This trial, though it accrued fantastic, did not meet its interim analysis targets for efficacy in CIS. It doesn't mean it's dead in the water. We're continuing to follow these patients. Patients have been allowed to stay on trial, but it's closed to accrual. So we'll have to see how that plays out. Merck is doing a very similar study with pembrolizumab, essentially same target population. This was overall response rate reported and updated at GU ASCO in February 19. Their initial CR rate looks pretty good. What's going to matter is the durability. So you have to meet a bar of about 40 to 50% initial CR rate and a durability somewhere at least in the 20 to 30% at 12 to 18 months. So stay tuned on that. And I'll just throw up the take-home messages. I will tell you that this is a really exciting time for drug development, and the FDA has been very forthright in creating this opportunity for us and our patients. And so there's another trial. This is, I'll just tell you about it. Colin Denny, it's about a decade-plus work of his at MD Anderson developing intravesical adenoviral-mediated delivery of interferon. Went through phase 1 development. We did a phase 2 trial in the Society of Urologic Oncology Clinical Trials Consortium, and we did the phase 3 trial. That trial's finished. They are also preparing an FDA application. The nice thing about this is it's a quarterly administration. So a single intravesical administration. If they have a CR, they can go into maintenance. And we've got some patients that are pushing out 2 years that have had a durable CR. So if they meet their primary endpoint, that could be very attractive. And there we go.
So we'll use our discussion time to continue just to touch on one more case that gives us a bit more to talk about with some updates in drugs and available treatments. But case 2 is a 76-year-old woman, gross hematuria, no tobacco history. She has tumors, as you can see in this illustration. The tumor is visible on white light, but also better visible with narrowband imaging, and again, kind of seeing a little carpeting that wasn't going to be very well appreciated with white light, but seeing that there are at least 3 tumors, 3 to 4 centimeters, 3 to 4 centimeters, and 1 centimeter. ureteroscopy was done because there was some tumor near the ureteral orifice. All of those tumors were low-grade TA, non-muscle invasive. Staging study is negative. And if we revisit our risk stratification, now we have multifocal, low-grade TA, and that puts her in the category of intermediate risk by the AUA guidelines. So for these guidelines, we should consider perioperative intravesical chemotherapy. We should consider induction intravesical chemotherapy. In the guidelines in 2016, they mentioned mitomycin or BCG, and we should give 1-year maintenance BCG if there is response seen with induction. However, we're in the BCG shortage. As Seth alluded, we should not use any intravesical BCG for low risk, and in intermediate risk, the joint statement through all of these different organizations made a recommendation that we should use intravesical chemo as the first-line option for intermediate risk non-muscle invasive bladder cancer. Those who require intravesical therapy should receive chemotherapy such as mitomycin, gemcitabine, epirubicin, or docetaxel instead of BCG. If we were going to need to give BCG, an alternative intravesical chemo should be used instead. So in some of the low and intermediate risk, Dr. Godoy is going to walk us through what we now have available in terms of intravesical chemo.
All right, thanks, Jen. So just a reminder, goals of therapy on the low intermediate risk group of non-invasive bladder cancer patients is actually control recurrence. So we know recurrence is still very important, but we're not so concerned about progression of disease anymore. So the recurrence risk is what we're addressing in all these therapies, and we're gonna. An additional goal is try to minimize toxicity of therapy, minimize the burden of the disease, and all the impacts that we have with management and also surveillance for these patients. So one important side goal, as I mentioned, is also make sure we're effectively ruling out high-risk disease or higher-risk disease in there, because those are the ones who will increase the risk of progression, and then we will need more aggressive therapy as well. So in terms of rationale, and this is also based on animal models, the idea of giving intravesical chemotherapy immediately after endoscopic resection in the bladder comes from the concept of eliminating any possible viable cells that might still be floating in the bladder and may reimplant or seed other areas. And of course, this has an impact on early recurrence, so possible residual cells, residual disease that might stay in the bladder. And additionally, some of these agents, they also have a direct cytotoxic effect in the cancer cells. So it's not only a prevention strategy, but also addressing further killing on the tumor cells. And you see the term immediate postoperative intravesical chemotherapy. Some of us will say just postoperative intravesical chemotherapy, but the timing can go up to 24 hours after the resection. Usually, the drug is given soon afterwards, while the patient is still in a PACU, catheter in place, and before being discharged home. And this concept is not new. We have multiple older studies starting from the 80s showing benefits with a single dose of a chemotherapy. Different agents are used. The study you're seeing, just go back to Jen, please.
Oh, sorry.
One more. Yeah, there we go. The study we're seeing on the screen, this is from Solsonas from Spain. It's one of the early studies on a mitomycin, showing that in terms of early recurrence and keeping some overall recurrence is maintained after just one single dose applied to the bladder after resection. But despite that data, and to be fair, the quality of data is not very strong. This modality, this technique has been underutilized, and that I think has several features. One is lack of familiarity with the drug and also the protocols. Not everyone is familiar, knows how to use it, the dose, for how long you keep it, possible side effects, how to manage. Poor local availability, additional costs. Mitomycin, for example, in the past few years has ramped up price very, very steeply. Lack of FDA approval for use these drugs in this indication, so it might be surprising, but except for the Valrubicin and the Thiothepa was the first one used, very, very early. All these other chemotherapy agents were never approved for intravesical use in this setting. And of course, fear of the adverse side effects and also serious complications. All of us have seen morbidity that mitomycin can have, especially if you have an undiagnosed or unidentified perforation in the bladder. So And in addition to all of that, part of these tumors that we treat, they are in the high-grade category. They are high-risk disease, and for that disease, we typically don't see much benefit. So putting together the real contraindication and all those features, I think, justify why it is being underutilized. Meta-analysis was first produced in 2005 to try to establish this as a standard of practice. It still haven't, worked so well. After 2 updates, the latest one, and that's what the data I'm showing here. This is the largest and the most recent compilation of the data. And you can see on the left side all the factors that stratify risks. And on the right side, you see the survival curve showing the patients who have single installation, they have a better time to recurrence. This meta-analysis included 13 studies. Over 2,000 patients, but they're all low and intermediate risk, and the relative risk reduction was about 35%, with a hazard ratio of 0.65. The absolute reduction was in 16% in 5 years, and the number needed to treat to avoid 1 recurrence within the 5 years of follow-up was 7. So this is an effective strategy in preventing recurrence of the disease. The observation of this data is that this is not very effective when patients have prior recurrence rate that is greater than 1 per year, so very active biologically disease, and also if they have the recurrence score based on the ORTC criteria greater than 5, those seems to be the ones that don't recur so well. Going back to the guidelines, I think the European guidelines reflect those recommendations, with some limitations in terms of the recurrence risk scores. AUA is a little more broad in terms of offering for patients with a low intermediate risk within the 24 hours. And then just a quick word about the mitomycin C. Despite the FDA approval, that's been the most widely available drug elsewhere, and is the most commonly one used in the U.S. The only problem, as I mentioned before, is actually toxicity. Sometimes it can get delayed healing for the bladder. You can get necrotic areas. The tumors, the resections takes a long time, and if you extravasate outside of the bladder, it has a very intense dissecant effect, and that might be very significant for the patient's recurrence. An alternative is the gemcitabine. Now, this is the SWOG 0337 data, came out recently last year, and there was a multi-center randomized clinical trial. Gemcitabine was randomized versus saline in this setting of a post-op immediate installation, and the tumors were not biopsied before, so this was suspected low-grade, but we had some high-grade tumors within that population. So you can see the curves in terms of a time to recurrence on the left, and for all patients, and on the right for the low grade only, and you see the benefit of the gemcitabine in terms of reducing recurrence. Just a very important reminder, we should not be offering post-operative intravesical therapy for patients with a high grade or high risk disease. Those patients actually need BCG as their first-line therapy, and data has been showing that it doesn't add any benefit or additional survival benefit. And just to quick, one final slide in terms of the adjuvant chemotherapy installation. This is actually what we offer afterwards. So in terms of the risk stratification, if they have low-risk disease, you don't need anything else, just immediate post-operative installation, and probably it's all you need. Go on your surveillance. If they have intermediate risk, then besides the post-op treatment, we go on the adjuvant installations. The protocols vary depending on the drug. I think the one that is most commonly used, most robust data, level 1 data from 2001, Jesse Al, is the mitomycin optimized protocol, is described here. We try to alkalinize urine, get the patients a little dehydrated, we concentrate the drug, and this helps, getting higher biological effect in the bladder. These are the curves on intention to treat analysis, and also the overall analysis in terms of optimized versus standard. And this is just a list of the guidelines, the AUA combined with SUO, non-muscle invasive, there's NCCN guidelines, the statements, this is the reference for the both BCG unresponsive consensus statement for your reference, and the clinical trials dashboard.
Thank you very much. Does anyone have any questions or comments or challenges?
Dr. Leonard, Okay, the FDA is against multi-use vials like Kenalog and testosterone. Why can't you just have Merck make smaller doses in smaller vials?
I'm going to put you in contact with them. I can't answer that from a packaging standpoint, but it's a hell of a great idea. I mean, I don't know what's involved, but happy to pass that suggestion along.
That's a great idea.
It's a great idea. Yep.
I will say the gemcitabine use as a perioperative medication was presented for the first time in December of 2017, and we've been doing that for almost 18 months in our clinic. We have not given anyone mitomycin, and now we don't use any mitomycin in the adjuvant setting either in clinic intravesical treatment. So,
I do.
yes. Thank you.
Interestingly, the trial from the gemcitabine was not randomized versus mitomycin.
Right.
Was just randomized versus saline. And but the toxicity profile is so much better, so
And the
much
cost.
safer, and cost is so much beneficial that I think it's being adopted very rapidly.
Yeah, I mean, I've dropped mitomycin completely in the perioperative setting, but as Guy showed you in that last Kaplan-Meier plot, as induction intravesical therapy for intermediate risk disease, it's a highly effective drug. And when you're giving it in that setting after the bladder's healed, those toxicity issues that you see in the perioperative setting don't exist. So by alkalinizing the urine, increasing the concentration, you drive mitomycin into the wall of the bladder, and that's the reason for the increased efficacy.
And the gemcitabine trials do that as well. So, any other questions? Thank you.